Good morning, good afternoon, good evening, depending on where you are in the world, and welcome to the next lecture on implementation research and scale-up. So I'm going to spend the next couple of minutes talking about applying one of the implementation research frameworks, RE-AIM, to scale-up. My name is Lisa Hirschhorn. I'm professor of medical social sciences and also at the Robert J. Havey Institute of Global Health at the Feinberg School of Medicine at Northwestern University in the US. I have nothing to disclose. And just a quick review. I know you probably all know this, but why do we actually talk about using frameworks in implementation science? Well, they're useful before you get started planning, but also adapting what you need to adapt during and after your implementation. It helps you understand what you expect to happen and what contextual factors you need to measure. It also very importantly helps answer what are the core implementation steps or components that are needed to be implemented and monitored, and why did your intervention work or did not. These can be as simple as a logic model, a driver diagram, or a more complex conceptual model. So what is RE-AIM? So RE-AIM, which stands for Reach, Effectiveness, Adoption, Implementation, and Maintenance, is a very widely used implementation science framework used for both evaluation and increasingly for planning. And it captures both implementation outcomes and effectiveness. And so here you can see from the Proctor logic model, sort of some of the outcomes that you will hear about when we talk about RE-AIM. It also includes maintenance, which is usually measured at the shorter term, but can also be expanded to focus on sustainment, which is a very important component of scale up. And at some point, we'll be talking a little bit about sustainability and scale in a different lecture. So here's the main dimensions that RE-AIM talks about. So there's reach, which would be the number, percentage, or representativeness of eligible patients who participated in the intervention. Answers the question, are you reaching the right people? And are you reaching those most in need? Effectiveness is really talking about the intervention itself. Does it achieve its goals? Is it better health? Is it reduced suffering? Is it prevention? Adoption would be the number or percentage of the people who are supposed to be delivering, the providers, the settings, are they actually doing it? Implementation, which typically in RE-AIM will include fidelity and cost, would be, is it actually being done the way that you want it to be done? And maintenance is whether or not this intervention is really continuing within and beyond your project time period. Does it get integrated into routine organizational practices? And importantly, does it maintain its effectiveness at the patient level? These are a number of other implementation outcomes. And certainly when people are measuring some of these outcomes, in addition, for example, to the fidelity, they might be measuring as well feasibility. Acceptability, very important when we think about including the patient or consumer's voice, the perception that it's agreeable, that they're actually willing to do that as well. So why do we actually think about doing this? Just a reminder about why this is so important. So let's say you have an evidence-based intervention, say a vaccine that's 94% effective. And if you're able to get 80% of the programs that are supposed to be delivering it to adopt it, and 80% of the time it's being done correctly at the right time, it's got the right cold chain, and it's reaching 80% of your population, your intended population, depending on who's eligible for this vaccine. And over time, about 80% of the organizations are able to sustain the delivery. What you'll actually see is that with that 80% threshold, instead of 94% effective, you're getting about a 38% population benefit. Now, when you scale, sometimes you get what we call voltage drop. And that's where it's not being delivered by the champions, potentially not as much support from a research team. And if you drop that threshold down to 50%, you only end up with about a 5.6 population benefit. So really important to do this as you're thinking about scale. Equally important, what we know is that if you're seeing a difference, for example, at scale, it's 80% in some areas, but 50% in others, that inequities will really be a problem, and they'll further reduce the effectiveness at a population level. So how can we use RE-AIM to measure scale-up process and outcomes? So one of the things to think about when you're moving from a single facility or a small project is you might need to expand where you're gathering data and even the level that's measured. Are you now working at a district level? What's your scalable unit? Do you have to start looking at the national level? It'll also help you understand how some of the changes, the differences in where you're implementing may actually affect the outcomes, as well as the strategies that you might choose. And importantly, where are new strategies needed or adaptation of the strategies you've chosen based on cultural differences or geographic reach or issues of urban versus rural. You'll need to continue to focus on variability as you add new sites, new populations, as you are adapting your strategies and implementation. And very importantly, when you're looking at sustainment of the implementation and outcomes at the organization, as well as at the individual level. Often, in addition, for implementation, when people are thinking about sustainability, there's usually a more focus on cost, equity, and adaptation that will often be critical to drive that sustainability. Now, I'm going to use a case study, which is scaling a community-wide campaign intervention to manage hypertension and weight loss from the US. This was a study that looked at the scale-up of this intervention called Tu Salud Si Cuenta. It was an evidence-based intervention on improving health outcomes related to chronic disease among lower-income Latinx populations in the US, particularly in the southern, around the southern border between US and Mexico. It included using lay health promoters or community health workers for social support, exercise, healthy eating, along with mass media messaging, environmental infrastructure change, and policies to achieve health outcomes. So you can see this was a complex intervention. It was culturally tailored to a predominantly Latinx population in the southern US. And the question was, what were the outcomes when they scaling this to 12 different communities? So as they operationalized it, what you can see is when they looked at reach, they were looking at the number of unique program participants who agreed to have the program follow-up visits. They focused on the community health worker follow-up visits. And this was the denominator was the total population. You can't go out and measure the total population. And so again, you might need to look for the size from different resources, and they use the census. In addition, they wanted to take a look to see whether it was actually representative of the population they wanted to reach. So they also took a look at things like ethnicity and poverty status compared to the general population. For effectiveness, they looked at improvements in blood pressure level or weight and BMI. And this was done also, they started to look at variability based on high or low exposure to the number of community health worker visits. In adoption, they looked at this more at the organizational or at the geographic level, and that was the number of municipalities or precincts that implemented the program versus those that were offered. And for that, they used sort of historical records or the contracts. Now, what's interesting is this only measures it again at the municipality level. It doesn't actually measure, for example, at the community health worker level, which might again begin to help you understand some of the variability in how it's actually implemented in reality. Implementation, they are relatively simple. They looked at fidelity, which was the number with minimum visits of the number of people who are enrolled. And so again, there's a lot of other questions you could ask about fidelity. Cost was not a specific measurement. And maintenance was the number of locations that still had an active program through the end of the study. And that was based on the number of locations that adopted it after January 2014. So relatively longer timeline, up to 5 years than we usually see. So what did they get from actually sort of focusing on these measures? The results were generally positive, although there were some nuances. They had close to 16,000 people who agreed to enrollment, and a follow-up visit was provided by the community health worker. Of that, it was very, very high in terms of their target population, 93.3% identified as Latino or Latina. 81% were below the federal poverty line, and that was very explicitly done as a targeting, and that was much higher than the 31% in the areas. So very, very high reach. Adoption was very high. Most of the municipalities agreed to adopt. Implementation was found to have moderate fidelity, and maintenance was high with 11 out of 12 municipalities. So what did they hear about effectiveness now that they knew some things about the implementation outcomes? Close to 66%, so 2/3 were newly diagnosed with hypertension through the program. So very, very high rates of getting people who were not even aware. And 41% of those who were newly diagnosed with hypertension improved either drop in blood pressure or normal blood pressure by the last community health worker visit. So very good sort of initial results there. 50% of the people they screened already knew they had hypertension, and with elevated BPs despite the diagnosis, and about half of those recovered to a normal BP by the last follow-up. And this was even more effective in the higher intervention exposure group. So the people that got more of the dose, more community health worker visits, had better blood pressure decrease as well as weight loss. So what were additional questions which actually would help further scale? And some of this was not actually in the paper, so things that you might want to think about either reporting or actually starting to measure. So how did the need for support and resulting fidelity and effectiveness differ? Was there any voltage drop that was seen? Did you see, for example, over time that perhaps the effectiveness dropped or the fidelity dropped? What were the factors of the municipality and community, and how did those affect implementation outcomes? Were there also individual factors at the patient level, gender, age, for example? Will the fidelity and effectiveness sustain over time, both at the population level, but also at the individual level? And how should these insights inform further scale up or even scale out if they want to address other health risks for this community? For example, smoking might be one. What other implementation outcomes would you have wanted to measure? Personally, I would love to have seen feasibility, but also acceptability and appropriateness and potentially cost, which is always important for maintenance. And what system level outcomes might you measure? Were there any unintended consequences of this in terms of people's reliance on the community health worker? Were they more or less likely to be going to the health centers? Where the health centers actually have the capacity to take up all these newly diagnosed patients? So how can REAIM, when you're thinking about sort of writing your proposal, when you're thinking about for scale up? So I would argue that it helps you better understand when evidence-based interventions are implemented across diverse real-world settings. It helps you determine what levels you will measure: individual, facility or community, larger area, national level. Explaining the results can also help identify these facilitators and barriers to implementation, as well as effectiveness. And we'll just sort of down here, Jane Foreman's written a very nice paper called REAIM Quest, which is actually a mixed methods way of applying REAIM. It really, I think, really gets you to focus to understand the variability between the initial and the scale and within the scale. So what strategies were used in the initial studies and how were those replicated? For example, practice facilitation by the study team versus transfer to existing structures. How does that impact implementation or maintenance? What contextual factors differed between your original and your scale up, and again, within the scale up sites? And again, how does that impact your outcomes? What local strategies might be needed? For example, if there's cultural differences in how people think about cooking or how people think about exercise or hypertension. And how did equity change during scale up and across settings? So was this a sort of uniform that everybody got better and 50%, for example, of people had their BP controlled? Or was that 50% actually among the people who potentially had more resources or less resources? So again, very important to always measure equity and to see whether you're actually improving the equity gap or actually making it worse. So thank you very much for your attention. And I'm hoping that this will be helpful as you start to think about which frameworks you will be using as you are designing your implementing at scale. Thank you.